Good morning. It's 11 o'clock. I think we are ready to start our session. This is an exciting session on hitting the first 90 target, lessons from the population-based surveys. And we have 5 speakers to take us through a very interesting set of presentations. Our first speaker is Danielle Baradas from CDC and based in Zambia. The topic is findings from the 2016 Zambia population-based HIV impact assessment, Zambia, HIV prevalence, incidence, and progress towards the 90-90-90 goals. Danielle, please, you have 12 minutes.
Thank you. Good morning, everyone. Here are my disclosures. So I'd like to begin with just a little bit of an overview of the context of Zambia. So Zambia is a country that is bordered by 8 other countries. The estimated population size in 2015 was about 15.4 million. The average household size is 5.1 members. About 68% of households have access to improved sources of drinking water, while about 40% have access to improved sanitation. Life expectancy at birth is, on average, 53 years. The most recent published data on HIV in Zambia come from the ZDHS, which was conducted in 2013 and 14. The data indicated that HIV/AIDS is the leading cause of morbidity and mortality among adults. About 13 out of 100 adults were living with HIV in Zambia. In 2015, UNAIDS modeled estimates projected that the lifetime risk of dying from HIV in Zambia was over 60%. Making progress toward meeting the UNAIDS targets for ending the AIDS epidemic by 2030 is a priority, a national priority in Zambia. So in order to understand how we're doing towards that and to gather more information on the current state of the epidemic in Zambia, in 2016, the Ministry of Health and partners conducted the Zambia study. That's the Zambia Population-Based HIV Impact Assessment. Zambia was a household-based national survey that included collection of behavioral and biomarker data for HIV testing and return of results and counseling. Partners included the Zambian Central Statistics Office, Tropical Diseases Research Center, the University Teaching Hospital, University of Zambia, ICAP at Columbia University, and the U.S. Centers for Disease Control and Prevention. The primary objectives of Zambia were to estimate for the first time national HIV incidence, national and provincial prevalence of viral load suppression, and progress towards meeting the 90-90-90 targets, using a household-based nationally representative sample of adults ages 15 to 59 years. Zambia also provided national estimates of pediatric HIV prevalence. Zambia was comprised of approximately 12,000 eligible households and 511 enumeration areas throughout the country, which are shown here in this map. Behavioral and clinical information was collected via adult and adolescent individual level questionnaires, while demographic information was collected via a household questionnaire. Blood samples for household HIV testing were collected per national guidelines. Confirmation of HIV seropositive results was done using the Genius supplemental assay, and for this analysis, ARV treatment was based on self-report. Viral load and limited antigen or lag avidity enzyme immunoassay testing was performed at a central lab on all HIV seropositive samples. Incidence is determined using results of lag avidity and viral load testing. All statistical analyses were completed using SAS survey procedures in order to account for the sampling scheme and produce weighted estimates. The scope of this presentation includes a description of the adult and pediatric HIV prevalence estimates, as well as HIV incidence estimates, and progress toward meeting the UNAIDS 90-90-90 targets among adults, all at the national level. The analytic sample included about 19,000 adults and 7,900 children who provided interviews and blood samples, yielding a response rate of approximately 68%. Participation by eligible adults was higher for women than for men. Now I'll share with you some of the findings. So overall HIV prevalence among adults aged 15 to 59 in Zambia in 2016 was 12%. This equated to about 960,000 people living with HIV. The overall prevalence was higher among females at about 14.6% compared to males at 9.3%. We observed increasing prevalence from ages 15 to 40 among women and ages 20 to 40 among men. HIV prevalence was greater than 20% among 35 to 49-year-old women and 40 to 54-year-old men. While disparities between female and male prevalence was also observed among younger adults, ages 15 to 39, those sex differences were not apparent among older populations, older adults. Here's a closer look at the pediatric data. So overall, pediatric HIV prevalence in Zambia was just under 1%. We didn't observe any differences by sex. However, the prevalence among 5 to 9-year-old males was about twice that of 0 to 4-year-old males. Here are the incidence data. So overall incidence among 15 to 59-year-olds was 0.67%. The incidence was higher among adult females at 1% versus males at 0.3%. For comparison's sake, I've shown here also the estimated incidence among 15 to 49-year-olds, which was 0.7% in Zambia. UNAIDS spectrum model estimates of HIV incidence in 2015 was 0.85%. Overall, viral load suppression was 59.1% among adults and was highest among the older adults ages 35 to 59 years. Again, we didn't observe any differences between males and females except in the 25 to 34-year age group, where females had a higher prevalence of viral load suppression than males. This slide shows conditional percentages related to the 90-90-90 targets. Overall in Zambia, 66% of HIV-positive adults were aware of their status. Of those who were aware of their status, 85% reported ARV use, and among those reporting ARV use, 89.3% were virally suppressed. We observed similar findings among males and females. So Zambia's HIV interventions have resulted in progress toward the UNAIDS 90-90-90 targets. Viral load suppression among those on treatment was especially promising to see and exciting given the prior lack of population-based data on this measure. The declining national HIV incidence depicts strides toward epidemic control. However, incidence among women remains unacceptably high. Further exploration of gaps in testing, ARV use, and viral load suppression is needed in order to better target expansion of HIV treatment services in Zambia. Our preliminary findings point toward the need to increase HIV testing, treatment, retention, and adherence for young men and young women. Some examples of the policy and programmatic implications that follow from these findings are a need to increase self-testing, as well as to have expanded hours of facilities and to have more and more male healthcare workers. We're also seeking to minimize delays in ART initiation by maximizing the number of ART sites, possibly through a process of decentralization. And we're looking at implementing Test and Start nationwide, as well as rolling out PrEP. All of these suggestions have been taken into account and incorporated into our most recent National HIV and AIDS Strategic Framework. I'd like to conclude by acknowledging the Zambia participants, without whom this work would not have been possible, as well as all of our colleagues here from the GRZ Ministry of Health, CSO, Tropical Diseases Research Center, ICAP, and CDC, and the rest of the Zambia study team. Thank you.
Thank you very much, Danielle. Could you wait over there? You might have to answer a couple of questions. So we have microphones to the left and to the right, back and front. If you have any questions, just get to one of those microphones and I will... All right, Rashida there.
Thank you. That was a lovely presentation. I had two questions. Firstly, did you do viral load testing only on those who reported taking antiretroviral therapy, or anybody who was HIV positive? And secondly, could you comment on the plans for improving viral load suppression in the adolescents and the younger age groups? The viral load suppression prevalence seems unacceptably low.
Sure. So we did viral load suppression testing only among the HIV positive, or among all HIV positive, not just those who are on ARVs. Viral load suppression among the younger age groups, I think part of the issue is that many of those young people are not presenting for testing, they're not getting on treatment, and also there's likely an issue of adherence. That's not something that we've been able to look at with the data that we have available now, but the Zambia data does also include biomarker data on ARV use, and when that becomes available, we'll be able to look more closely at that among young people.
All right. Questioner to my left.
Thank you. Gaël Caquin from FGH in Mozambique. So thank you for sharing your results. Maybe could you comment for the audience around the sex ratio difference between in kids? Because you have shown that, for example, there are many more males on treatment than girls, and that's not always consistent across cohorts. And as it's particularly striking in your study, I think it would be good if we could have some comments around the fact that we have sometimes unbalanced cohort in kids between male and woman.
Actually, didn't show any treatment data on young people, on the pediatric population for males and females. Sorry.
So not on treatment, but the cohorts sometimes are unbalanced. You may have more males surviving in some others, sometimes you have less. And so overall, have you been able to reflect on the fact that you have an unbalanced cohort between young patients, male and female? And what are the... Because, for example, it's said that boys tends to die more in utero than girls when they are exposed to HIV. There may be also behavior issues from a mother regarding a boy or a girl in terms of access to care. So I was just wondering if you had some insight into those issues.
All right, so you're talking about the prevalence of HIV among the male children versus the female children. Is that?
Yeah, I mean, surviving at least. Yeah.
Okay. You know, I don't know why that is. It could be due to some of maybe nutritional status issues. Maybe it has something to do with the survival effect. Maybe it has to do with frequency of breastfeeding among HIV-positive mothers. Unfortunately, these data aren't equipped for us to be able to test any of those hypotheses. But I did note that difference in the presentation because I think it is something that's interesting, and if it is a real finding, worth investigating further.
All right, thank you. To my right, front microphone.
Thank you. Dennis Nash from the City University of New York. Great presentation. I'm curious to hear a little bit about more about your incidence assay. Did you do local validation work on that? And I'm sorry if I missed it. Did you measure CD4 as well? And how are you going to use your incidence data to improve prevention?
So we did also do Cd4 testing. That data will be available in the third and final release of the Zambia data set to us, and so we'll be able to do some comparisons of that. There was not local validation of the incidence data, but there was some validation done, I believe, in Atlanta, and perhaps one of our other colleagues who is going to be participating later can provide a little bit more information on that. And then the question around how we're going to use our incidence data for prevention efforts. So what we did see was that incidence is highest in 15 to 24-year-olds, particularly women. And so we're planning to target efforts towards reaching that group, whether it's through increased education or testing, meeting them where they are, trying to implement more self-testing. Hopefully, we can also work with some of our partners who are working in country who are doing more qualitative work to try to understand how to get more young women and girls into testing and counseling and treatment. There's also the DREAMS initiative is going on in Zambia, and we're working also with them to map the hot spots where young girls are. So we're really trying to focus in on young women and young men.
I thought I saw a mention of PrEP up there, which is what I was asking.
Yes, there is mention, there's been talk about nationally rolling out PrEP. It hasn't really been discussed, though, how they're going to prioritize that, whether it will be among young people, whether it be among key populations or discordant couples. We're still in the formative stages of how that will be done.
Thanks.
Thank you. Did you have a question? Yeah, go ahead.
Hi, I'm Ginny Schubert from Housing Works in New York. Thank you. The data is very exciting. Data you were able to collect on social and cultural drivers like food insecurity and housing status, and also whether you were able in the urban settings like Lusaka to sample households in the informal settlements.
So I do not think we did sampling in the informal settings, settlements in Lusaka province. But we do have information, some information on poverty, the type of whether or not electricity, the type of fuel used for cooking, very basic indicators. We didn't want to overburden respondents, but there are some basic socio-demographic indicators that, again, we'll get in that third tranche of data, and we'll be able to look more closely at those indicators and how they relate to our outcomes.
So, sorry, we'll have to move on. Thank you very much, Danielle. We'll move on to our next presentation by Avi Hakim, no relation of mine, from the United States. He is with the CDC, and his presentation, believe it, is going to be correlates of being outside the 90-90-90 cascade among adults aged 15 to 64 years in Zimbabwe.
Good morning, and thank you very much. So, as Dr. Hakim said, I'll be presenting on correlates of being outside the 90-90 cascade, results from the Zimbabwe population-based HIV impact assessment. Zimbabwe is located in southern Africa and has a population of approximately 14.5 million people. In 2015, UNAIDS estimated HIV prevalence in Zimbabwe to be 14.7% amongst 15 to 49-year-olds. HIV treatment is free for Zimbabweans, and in 2013, Zimbabwe changed its treatment eligibility criteria to include anyone with CD4 less than 500 cells per microliter. In December 2016, the country adopted a treat-all approach. ZIMFIA was conducted in October 2015 to August 2016 with the aim of assessing national HIV incidence and the 90-90-90 cascade at a subnational level. Here, we aim to describe the three 90s among 15 to 64-year-olds in Zimbabwe and correlates of being outside each level of the cascade, or being in the 10-10-10. ZIMFIA was a two-stage cluster-based nationally representative household survey using population proportional to size within strata. Stage 1 included 500 enumeration areas across 10 strata, and Stage 2 included sampling of 15,009 households. Survey participation began with a household interview, followed by individual interview and HIV testing. Testing followed the national algorithm of Determine, First Response for confirmation, and StatPack as the tiebreaker. Test results were returned the day of survey participation. Laboratory testing included Genius for quality assurance and viral load with the Roche Cobas AmpliPrep Cobas TACMan platform. Viral load results were returned to participants at a health facility in their district after approximately 10 weeks. Data were weighted for survey design and non-response, and the multivariate models included variables significant at p less than 0.1 in bivariate analysis and p less than 0.05 in multivariate analysis. These demographic and behavioral variables were considered in bivariate analysis for inclusion in multivariate analysis. Our outcome measures focus on the 10-10-10 cascade. The first 10 is people who are HIV infected and unaware of their HIV status. The second 10 are people who are aware of their HIV infection but not on treatment. And the third 10 are people who are on treatment but not virally suppressed. All outcome measures, save for viral suppression, were self-reported. And now the results. We selected 15,009 households for participation. Of the nearly 14,000 occupied, 83.9% consented to be interviewed. Here we see the number of eligible males and females in consenting households. 82.3% of eligible males in consenting households consented to an interview, and of them, 90.2% consented to HIV testing. Participation was higher among females, with 93.9% consenting to an interview, and of them, 91.8% consenting to HIV testing. We estimated national HIV prevalence at 14.1%, ranging from 11.0% in Manicaland in the east to 21.7% in Matabeleland south. I'd now like to turn to Zimbabwe's testing and treatment cascade. We estimate that there were 1.15 million people living with HIV in Zimbabwe, 72.9% of whom were aware of their HIV infection, and 27.1% were not. Of those aware of their infection, 86.8% were on ART, and 13.2% were not. And of those on ART, 86.5% were virally suppressed, and 13.5% were not. Amongst all people living with HIV, 63.3% were on treatment, compared to the goal of 81%, and 59.6% were virally suppressed, compared to the goal of 73%. While traditionally we focus on those engaged in services, represented in the light gold color at the bottom of each bar, for the rest of the presentation, I will focus on the remaining people, those not engaged in services, or the tens, represented in brighter gold at the top of each bar. In our first multivariate model, we found that age, gender, marital status, and condom use at last sex in the last 12 months were all significantly associated with being unaware of HIV infection. The graph on the left shows that approximately half of 15 to 24-year-olds and 1/3 of 25 to 34-year-olds were unaware of their HIV infection. In multivariate analysis, we found that those aged 15 to 24 years were nearly 5 times as likely to be unaware of their HIV infection as those aged 55 to 64 years. Males were nearly twice as likely as females to be unaware of their infection. And compared to widows, those who were never married or who were divorced or separated were more likely to be unaware of their infection. And finally, individuals who did not use a condom at last sex in the last 12 months were 3.5 times as likely to be unaware of their infection as those who did not have sex in the last 12 months. Though significant in bivariate analysis, Education and number of sex partners in the last 12 months were not significant in multivariate analysis. The next model concerns those who are aware of their HIV infection, but who are not on treatment. Age, condom use at last sex in the last year, and number of sex partners in the last year were significantly associated with being aware but not on treatment. In terms of age, those aged less than 44 years were roughly 3 to 4.5 times as likely to not be on treatment as those aged 55 to 64 years. Those not using a condom at last sex in the last 12 months were 3 times as likely to not be on treatment as those who did not have sex in the last 12 months. Sorry. There we are. And nearly 1/4 of individuals with 2 or more sex partners in the last 12 months were aware but not on treatment. This group was nearly twice as likely to not be on treatment as those with only one partner. Though significant in bivariate analysis, education and marital status were not significant in multivariate analysis. The third and final model shows age and gender to be significantly associated with being on treatment but not virally suppressed. Among those on treatment, individuals aged less than 45 years were upwards of 3 times as likely to not be virally suppressed compared to those aged 55 to 64 years. And males were more likely than females to be unsuppressed. Though significant in bivariate analysis, condom use at last sex in the last 12 months was not significant in multivariate analysis. Based on self-reported awareness and treatment status, we estimate that among 15 to 64-year-olds in Zimbabwe, there are 311,000 people not aware of their HIV status, and 422,000 people not on treatment. And based on viral load testing, we estimate that there are 465,000 people who are not virally suppressed. Our survey is not without limitations. Results rely on self-reported awareness and treatment status. Additionally, the proportion not virally suppressed includes people who may have just started treatment and would not be virally suppressed yet. Moving forward, we plan to test specimens for presence of antiretroviral medications, explore interactions between key variables, examine reasons for not being in the 10-10-10 cascade, or rather for being in the 10-10-10 cascade, and estimate population attributable risks. In conclusion, males, people aged less than 45 years of age, the never married or divorced separated, and those not using condoms in the last 12 months, and those with 2 or more sex partners in the last 12 months, were most likely not to be reaching UNAIDS goals. These factors should be carefully considered when developing policies and services. As Zimfia was conducted just before Treat All was rolled out in Zimbabwe, our results provide a valuable baseline for impact of the Treat All approach. I'd like to acknowledge and thank our participants, field workers, as well as colleagues at the Zimbabwe Ministry of Health and Childcare, the U.S. Centers for Disease Control and Prevention, ICAP at Columbia University, Zimbabwe National AIDS Council, the Zimbabwe National Statistics Agency, the Biomedical Research and Training Institute in Zimbabwe, Lancet Laboratories, the Statistical Center for HIV/AIDS Research and Prevention, and Westat. Thank you.
Yes, thank you very much, Avi. Very interesting findings. Any questions? Maybe just to start off, you were very careful in your conclusion there that these observations should be taken on board when formulating policies and practices. Can you go a little further? Is it possible for you to, I mean, one could have probably guessed a number of these observations, but now that there is data, are you able to begin to suggest interventions to be able to improve on the 1990s, which are already looking good, but obviously one can improve them further?
Indeed, they are looking good in Zimbabwe. And You know, there are very basic things from focusing on young people and males, as has been discussed in many sessions thus far. For me, one of the beauties of these surveys, as compared to clinic-based surveys, is that we're able to reach people who are outside of the Cascade, people who are not accessing services. And so we were able to ask people why they're not engaged in services, why they've never been tested for HIV or not been tested recently. And so those results are forthcoming, and we will be able to look at them to understand the reasons for non-engagement, and then that will provide better insight for how to engage people in services.
Thank you. To my left.
Thank you, Chairperson. I'm quite glad with your presentation, well articulated and makes a lot of sense. And I'm also grateful that you are able to highlight the challenges you face in terms of self-reported information. However, what I would like to know from you is, did you measure the margin of error on some of those key self-reported issues? And if you did, are you able to share with us how much you think they could be deviating from the normal? My name is Namunda Mutombo from SFH Zambia. Thank you.
Thank you very much for the question. We do have precision estimates for each of these estimates. As I said, we'll be going back and testing HIV-positive specimens for ARVs, and that will better enable us to assess the validity of the self-reported responses to see whether or not people who said they have never tested positive for HIV or that they're not on treatment actually do have ARV medications within their blood, and that will allow us to redo our analysis and compare the self-reported results to the adjusted results. Thank you.
To my right.
Thanks so much. I'm Saeed Ahmed from Malawi. Thanks for the presentation. I'm wondering about this unaware group. Are you able to further break it down into people who are unaware because they've never been tested and unaware because they've had a test and think they're HIV negative?
We are able to do that. I don't have those data offhand, but that is something that we'll be delving deeper into in our additional analyses, not just to see whether or not someone has ever tested, but being unaware based on testing in the last 6 months versus testing in the last 2 years, et cetera. Thank you.
I didn't see it. Thanks.
You, to my left.
Oh, I'm Sally Blower at UCLA. Great presentation. I have, did you look at differences for the 1010, both geographically and in terms of accessibility to treatment, and specifically the urban-rural divide?
We did. Province and urban-rural divide were not associated with any of the 310s at the bivariate level. Eventually, we'll be getting more data on specific geolocations of people, as well as reasons for non-engagement. So then we'll be able to do further analyses to see if distance was a self-reported reason for non-engagement, as well as possibly looking geographically at the extent to which specific distance from a health facility is a factor in non-engagement.
To my right front.
Marcel Yotebian, the Ohio State University. I just wanted to know, given this was household survey, are you able to distinguish between those who do not be discordant couple among those who do not know their status? Because as you well know, many of those people get their HIV in stable relationship, not necessarily married relationship, but stable relationship. So yeah, do you have data on link on their partner if they live in the same household?
We do have those data, yes.
And are you able to link that? Have you linked that?
We have linked it. Unfortunately, I don't have those data offhand to see percentage of households which were discordant.
Okay, thank you.
Thanks.
Yes, that will be the last question.
Thank you.
Thank you. Sorry. There's one more
That will be
question.
the last one, yeah.
I think, yeah.
The next one, yeah.
Sorry, in the back. Didn't see you.
I'm Stephen from MSF France. I think it's interesting that you're looking at the 10-10-10. I think it would be interesting to look at the 90-90-90 10-10-10 model as a dynamic model where individuals transit from either the 90-90-90 group to the 10-10-10 group over time, so that then we understand the correlates or the risk factors of dropping in and out of the two cohorts. Do you think you have sufficient information to construct a dynamic model to predict which patients are likely to fall back and forth from between these two groups?
Good question. As a cross-sectional study, we're unable to track people over time. So while we know about the current engagement in services of individuals, we don't know whether or not they ever took a leave of absence. For example, started treatment, then stopped, were at one point virally suppressed, then weren't, and now may be virally suppressed again. But that's definitely a very valuable area for future research.
Thank you very much,
Thank you.
Dr. Avi Hakim. Our next presenter is Nelly Wadonda Kabondo, Malawi U.S. Embassy and CDC. She will be presenting. The title of her talk is 90-90-90 Targets in HIV-Positive Women Using Results from the MFIA, a Malawi Success Story. Nelly?
Thank you. I will be presenting, as has been mentioned, on the progress towards achieving 90-90 targets in Malawian women. In 2015, UNAIDS estimated HIV prevalence for Malawi to be 9.1%. As can be seen on the map, the prevalence was higher in the southern region. ART and Pmtct program in Malawi started in 2004, and in 2011, option B+ was introduced. Soon after starting the ART program, Minister of Health came up with a way to monitor the response in the country, and the quarterly supervision was introduced. Through this quarterly supervision, Malawi is able to know the number of people tested in each quarter, number of people identified positives, number of people put on ART, and the number of people continuing on treatment. However, this is a facility-based system, and it does not monitor what is happening at population level. So at population level, we are not able to know how many new cases are we identifying and what is the level of viral suppression or ART coverage. MFIA was then conducted in between 2015 and 2016, and this survey introduced an opportunity for us to be able to assess what we cannot assess or monitor using the facility-based monitoring system, such as the viral load suppression or progress towards 90-90-90. So the primary objectives of MFIA were twofold: to estimate national rate of new HIV infection at population level and for 15 to 64, and to estimate national and subnational prevalence of viral load suppression among this population. I should mention that we had several other secondary objectives, but I could not list all of them here. This was a two-stage cluster survey that selected about 500 enumeration areas and targeted between 24 and 29,000 participants. HIV testing was done in the field at the households, and the results were retained immediately. The testing in the households used a national algorithm, but for all those who were identified as positives in the households were confirmed at the lab using Genius. So we had set up satellite labs across the country to confirm HIV testing. Viral tests were done at a central laboratory at one lab. For this current analysis, all we have done is a descriptive analysis using Stata and SAS. And data has been weighted for design and non-response using jackknife replication method for estimating variance. So what is the current objective for this presentation I'm making? So we assessed in this presentation progress towards 1990 among women. The reason we focused on women is because, as I've mentioned previously, Malawi was the first country to introduce option B+, and we wanted to see what progress has it made on achieving 1990 in the women. And we also wanted to see if there are any gaps. Where are these gaps geographically and by age? I will now talk about results. So as I said, I'm focusing on women. 12,235 women were eligible to participate in the study. And of those who were eligible, 93% agreed to be interviewed, of whom 88% accepted blood draw. Looking at prevalence, overall, among women aged 15 to 64, prevalence was 12.8%. And in those aged 15 to 49, it was 12.4%. The prevalence varied by age, from 2% in those 15 to 59 to about 25%, peaking at the age of 40 to 44 at about 25%. So we also looked at the first 90, as I've said. In these two graphs I'm showing, to the left, I'm showing prevalence and awareness of HIV status by region or by zone. That's geographical zone. And we can see that HIV, awareness of HIV status was higher among geographical areas that had high HIV prevalence, except for Blantyre, that had highest HIV prevalence, but was one of the regions with lowest knowledge or awareness of HIV positive status. If we look at it by age, we see that across all age groups, the 90% had not been achieved. But for those above the age of 30, they were on the right trajectory for achieving the 90 targets, the first 90 targets. The young women, 15 to 24, were lagging behind. If we look at the second 90, progress towards second 90, we notice that overall, 65% of PLHIV reported to be on ART in the country. 69.5% was reported in females. Self-report ART coverage by zone was higher among areas with higher HIV prevalence. Again, lower in Blantyre, which had the highest prevalence. Looking at it by age, we note that HIV coverage of ART was higher among older populations. For those aged above 30, they look to be on the right trajectory for achieving the first 90, which by this time we are supposed to be seeing about 81% because this is population level. And if we look at the age groups that are highly affected, the 40 to 49, these are very close to achieving the second 90 targets. However, the younger women are still lagging behind. So looking at third 90, when we looked at third 90, we observed that in Malawi, 68.7% have achieved viral suppression. So 68.7% of all PLA HIV in Malawi have achieved viral suppression. This was 73% in females, which means that in Malawi, we can confidently say that the third 90 has been achieved in women at population level. But looking at it by age, we notice that those aged 30 and above have surpassed the third 90 target, because by this time we should be looking at 73%. But the younger women are still lagging behind. So then we compared what is happening in males, compared the females to what is happening to males. We can see that on each and every 90, females are doing better than women. So while the women have achieved the third 90, females are doing better than men. While the females have achieved the third 90, the men are still lagging behind. However, if we use the self-report data, that is looking at 90-90, so we see that what we see at population level is not what we see from the self-report data. In the self-report data, if we are to multiply the first 90, multiply by second 90, and multiply by third 90, we note that for the males, 52% have achieved viral suppression, and for females, 73% have achieved viral suppression, and for total population is 59%, which is not what we have seen or observed at population level using biological data. As has been mentioned by the previous speakers, in this study we also we are also looking at metabolites, or looking at ARVs in the blood. And we hope that that will help us to explain the differences that we are seeing between the self-report data and the data that we are observing using biological markers. We will be able to know whether these differences are due to false report or is due to elite population. However, another thing to note from this data in Malawi is that once people are put on a treatment, they achieve the second and the third 90. So there is a high likelihood that people will achieve the second 90 and the third 90 if the first 90 is achieved. So looking at what are the implications for programming, we have done a lot of analysis in Malawi, looking at the geographical distribution, where is the gap. And we estimate that there are about 354,000 people who have not been virally suppressed in Malawi. And out of these 354 who are not virally suppressed, we looked at where are they by age, where are they by population. So we have done all those analyses. But what I'm showing you here is by age. So if we look at by age, in gray, the bars in gray and in blue, you see that in 2004, we had more women who were not virally suppressed than men. But at the current stage, we see that more men are not virally suppressed than women. We have reversed that. So in conclusion, I can say that Malawi is on track to achieving the 1990 targets. And that women above the age of 30 have already achieved the 3090 target. And we can also speculate that option B+ is most likely to explain these achievements in women, because the option B+ focuses on women. More work still needs to be done in younger women, particularly on the first 90. And more work needs to be done in other geographical areas, particularly in Blantyre, that has higher HIV prevalence but lowest suppression. Malawi program needs also to focus in men in addition to the young women. I would like to thank all the participants in MFIA and the field teams that tirelessly worked day and night to achieve these results. All collaborating institutions, and particularly Ministry of Health, that led the implementation of this survey. And I would also like to mention in particular Dr. Mwansambo, who is in here and was the chair of the steering committee from the highest office in the Ministry of Health. Thank you very much.
Thank you, Nelly. If you just wait over there, we have time for probably only one question, if there is anybody with a burning question. All right, so to my left at the rear, yeah, go ahead.
Hello.
Go ahead.
My name is Colin Siwoji from Brighton. Thank you for a great presentation. There was a lot said about poor retention on ART following the introduction of option B+ in Malawi. But you've just presented data showing that women you have about 73% of women living with HIV that are virally suppressed. So what has Malawi done to turn this around?
Yeah, so we were also surprised because that's what we have been made to believe, that there is poor retention from option B+. But the MFIA data does not show that. It is also possible that most of the women are self-transferring, and people think that they are not being retained on ART. Because what we have seen is that most of them, according to the self-report and according to also what we have seen using viral load data, is that most of the women are on ART and are actually suppressed.
All right, thank you very much, Nelly. My co-chair is Virginie Supervi from INSERM, Paris, France. She will take over and introduce the rest of the speakers.
Okay, thank you. Good morning, everybody. So, as you saw, the first three presentations mainly focus on the adult population. Now we are going to have a presentation on the HIV burden among children in Malawi. And it's a pleasure to introduce Shashi Junalagada, who is an epidemiologist currently working at the US CDC. And her presentation then, the title is Children Living with HIV in Malawi, First Survey-Based Measurement of National Pediatrics HIV Prevalence and Viral Suppression. Shashi.
Good morning, everyone. You just heard Nelly discuss findings based on the adult data that we collected in MFIA. I'll be focusing on the children that participated in the survey. It's a real honor to present these results on behalf of the MFIA study team. Based on the 2015 spectrum model, there were an estimated 84,000 children living with HIV in Malawi. As you're aware, these estimates are derived indirectly, taking into account a varied set of data inputs and assumptions. Accurate estimation of pediatric burden is essential not only for forecasting the need for pediatric formulations, but also to measure performance of programs in children, such as testing coverage, use of effective treatment, viral suppression in children, planning for prevention needs, assessing the performance of Pmtct programs, and so on. These important data needs are being addressed through the population-based HIV impact assessments, which are household surveys that are powered to directly measure pediatric HIV prevalence at the national level in 13 countries in sub-Saharan Africa. Here we are presenting results, select few results based on the survey that was conducted in Malawi, or MFIA. You're familiar with the acronym now. So one of the secondary objectives of the survey was to estimate pediatric HIV prevalence at the national level. Like Nelly mentioned, the survey was conducted from November 2015 to August 2016. It was a two-stage cluster design involving 500 enumeration areas that are shown in black dots on the map, spread across 7 geographical zones. The sample involved about 14,000 plus households, but an important point to note here was that only half of the sample households were included for procedures in children in order to meet the sample size required to estimate national pediatric HIV prevalence. For the current analysis, we estimated the national pediatric prevalence of HIV in the country. We estimated the number of children living with HIV and viral suppression in all HIV-positive children. I'll talk a little bit about sample testing and return of results. In children that were 0 to 17 months old, we screened them for HIV using a rapid test at the household, and they underwent confirmation through DNA PCR, or EID. Children who were 18 months to 14-year-old were tested for HIV at the household using the two-stage national algorithm, and those who tested positive on both the rapid tests underwent further HIV confirmation using a Genius assay. All children who were confirmed HIV positive, that is either EID positive or a Genius positive, got a viral load measurement. The results that were returned are shown on the slide in yellow font. For the 18 months to 14-year-olds, their HIV test results were returned at the household immediately following testing, either to a guardian or a parent. And then the viral load results and the EID results were returned a few weeks later to a clinic that was selected by the participants. A point to note here is that positive EID results, we made efforts to actually deliver them to the household. For this analysis, we estimated HIV prevalence using confirmed HIV status, that is either EID positive or a Genius confirmed HIV positive status. The number of children living with HIV was estimated using the projected population of the 0 to 14-year-olds in Malawi using their census data. And the viral suppression was defined as HIV RNA levels less than 1,000 copies per milliliter. The survey data was weighted for design, non-response, and non-coverage, and that was the data that we used for these analyses. And here now are the results. From half of the sampled households that were sub-selected for child procedures, we had a sample of 10,711 children, of whom 93% met our eligibility criteria. Of those, 6,166 participated in blood draw and HIV testing, giving us a response rate of a weighted response rate of 59%. The weighted response rate for blood draw and HIV testing is also shown here in 5-year age groups, and the number of children who tested positive in each of these 5-year age groups is shown in this last row of boxes. These here are our key results. The Malawi national HIV prevalence in children was estimated to be 1.5%. the number of children, which translates to a total of about 120 children living with HIV in the country. Note that this is more than what we expected based on the 2015 spectrum model of 84,000. And the viral suppression among all HIV-positive children was estimated to be 41%. Looking at prevalence by age, we noticed in the 10 to 14-year-olds it was 2.1% and about 1.1% in the 0 to 4-year-olds. And we wanted to examine this a little further as it seems to track the evolution of the Pmtct program in Malawi. So we took the same prevalence chart we saw earlier, and instead of age, we put the year of birth here on the x-axis. So for the 10 to 14-year-olds in the survey, they were born between 2002 to 2006, and the 0 to 4-year-olds who participated in our survey were born between 2012 to 2016. And remember that our fieldwork was conducted between 2015 and 16. The Pmtct program in Malawi started in a small way in 2002, which is when the 14-year-olds in our survey were born. And it involved AZT and nevirapine. Scaled up over time, and it was really only in 2011 when option B plus was introduced and scaled up nationally by 2012. That's when the 0 to 4-year-olds in our survey were born, entirely during the era of post-option B plus implementation. Just to dwell a little bit more on the slide, a couple of points to note. We do think that the prevalence estimate, particularly in the older children, is likely to be an underestimate given mortality. And also we do know that although there is a difference in the estimates across both cohorts, we know that the confidence intervals are overlapping here. This map here shows the geographic variation in pediatric HIV prevalence. 0.5% in the Central West, about 3% in the Southeast zone. Using zonal prevalence estimates and the population projection for the 0 to 14-year-olds, we estimated that about 70% of children living with HIV in the country live in this southern zone. Looking here at viral suppression among children by age, remember that overall in the 0 to 14-year-olds, it was estimated to be 41%. In the 0 to 4-year-olds, we estimated that at 19%. In the older age groups, it was slightly higher, but still quite suboptimal and much low compared to what we saw in the adults. So just to put these last couple of slides into context, based on the 2015 spectrum estimates of CLHIV of 84,000, the treatment coverage in children was reported at 61%. The recently released 2016 spectrum estimates of CLHIV in Malawi is 110,000. And remember that through MPHIA, we estimated that to be 120,000. It's important to note that the spectrum estimate of 110,000 includes the MPHIA pediatric prevalence data as one of the inputs into the estimation process. There have also been several other methodologic changes that have been made to the pediatric estimation process. Nonetheless, we now have a larger number of children living with HIV, and the treatment coverage may actually be lower than what we previously thought. The viral suppression in children is actually not an output from spectrum, and MPHIA was a first attempt at measuring this at a community level, and we found that to be quite low at 41%. So a lot of points to make on this slide, but two key issues is, one, there are more children living with HIV in Malawi than we previously thought, and their viral suppression is quite low. So to understand these results a little better, our next step is to attempt to build a treatment cascade in children. We have additional data that was collected in MPHIA that is soon going to be available for us to better understand the first 90. So did the parent or guardian actually report a child's HIV positive status? And if this indicator is low, it points towards possibly a need to strengthen case finding in children. We also have enormous amount of treatment data on children. And then we will plan on looking at viral suppression, accounting for awareness and treatment status to better explain this low viral suppression that we're seeing at a community level. So there's a lot more to come on this topic, so do stay tuned. And with that, I'd like to acknowledge the following, particularly the participants in our survey and the field teams and the rest of the colleagues listed here. And thank you.
Thank you, Shashi, for this great study and presentation. So we'll take one question on the right.
Marcel Yotebien, the Ohio State. How do you, I was curious because the viral suppression among 0 to 4 is less than 20%. From the previous speaker talked about that option B plus may be working very well, but if option B plus was working very well, we were expecting that those children should be, because they are diagnosed very early and put on treatment quite early, they should be the one having the higher level of viral suppression. How do you explain that, or at least be equal to the other who are diagnosed, who are being diagnosed when they get sick and before they come to hospital?
My understanding is this has to do with the treatment regimen that's used in the 0 to 4-year-olds in Malawi. I think Malawi has made only a very recent shift to the WHO recommended leponavir-based regimen for the youngest children. Some our guess is that the low viral suppression is to do with the nevirapine exposure and development of resistance in these children, or possibly not responding to treatment as effectively. But the good news is that based on these data, the country has made an accelerated shift to the new recommendations, and they should hopefully see this issue go away soon.
In the back.
Taha, Johns Hopkins University. Can you comment on the mode of transmission for the older children, those who are close to 14, take into account that probably at that time when they were born, if these are vertically infected, probably it was only single dose nevirapine. And did you collect any information about mortality of children within the household? Or can you can you merge your data or just have some idea about mortality from the DHS?
Right, so we did collect data on mortality in children at the household level. We don't have that available yet, but it's soon to be coming. About your first question about the adolescents, if I understand correctly, are you implying possibly horizontal modes of transmission playing a role in their higher prevalence?
Yes, just, I mean, are these children who have been infected perinatally and then they have survived up to 14 years without just single dose nevirapine?
We actually don't have that information in terms of, no, actually, I'm sorry about that. We do have information about when their HIV diagnosis occurred, so we will be able to tell if it was closer to 0 to 5 years of age or closer to 12 years of age. But yeah, we will be able to make that distinction. But for now, just based on the data that we do have, when we looked at gender-based difference, sex-based differences between in the 10 to 14 age group, we didn't see any difference. With the hypothesis that possibly in the young girls there may be sexual activity that might play a role in transmission, but we didn't see that difference based on the data that we have.
Okay, last two questions in the back on my left. Yeah. No, you don't want to ask a question? Okay, so sorry. On the right then.
Sorry, if I could just come back to the question the previous speaker asked about the low viral suppression in the 0 to 4-year-olds. Is that got to do with regimen or the fact that despite being in a Pmtct program, EID is not done and they're not started on treatment?
So
is this to do with diagnosis or with the treatment regimen per se?
Right. So Not directly for the children that I presented about, but we did ask mothers about their births in the last 3 years and their access to Pmtct programs and EID testing and the whole Pmtct Cascade related questions. And what I don't have the numbers off the top of my head, but we did see a really high coverage of EID testing in the sample that we have. You know, I don't know if Nelly wants to talk a little bit more about the Pmtct program in Malawi, but I think they've done a good job with testing and diagnosis.
And the results being returned and babies being started or not, because necessarily EID testing does not necessarily translate into actually starting treatment.
Right. And that's something that we can certainly look into. That's a good point.
Yeah, so I just wanted to add that, yes, as we have a strong Option B Plus program in Malawi, the data show that most of the women are being tested and the children are being tested, but not to the adequate levels that we would like to see. So that's, I think, one major weakness of our Option B Plus, that most of the children are not being tested early enough. That's what we have seen, that they are not being tested early enough, and that some of them are dropping off from the program as well. So even if they get tested, they are usually lost to follow up the children.
Okay, thank you. So we will pass to the last presentation. So we are going to change, continent and also the kind of data that were used to bring information on the undiagnosed and the incidence. It's a pleasure for me to introduce Art van Siegen, who is a senior researcher with the Athena National HIV Cohort, which monitor HIV patients in the Netherlands. And Art has been developing with ECDC a tool that he will present today. Art?
Okay, good morning, everyone. I would like to thank the organizers for inviting us to present our work on estimating HIV incidence and the undiagnosed population in the European Union, European Economic Area. And I'm presenting this work on behalf of my co-authors from the European Centre for Disease Prevention and Control, the ECDC in Stockholm, and also on behalf of the ECDC HIV/AIDS Surveillance and Dublin Declaration networks. These are my disclosures. So each year, approximately 30,000 people are newly diagnosed with HIV in the 31 countries of the European Union, European Economic Area, EU-EEA. The map on the right shows which countries actually belong to this region. So essentially, they include all the countries in Europe to the west of the former Soviet Union, except for Switzerland and some countries in the Western Balkans, and also some smaller countries like Monaco and Andorra. Previously, we estimated 122,000 people were living with undiagnosed HIV by the end of 2015, and this was about 15% of the total number of people living with HIV in the region. The aim of the current analysis is to update this number and estimate also by sub-region and stratify this undiagnosed population by Cd4 cell counts. The data I'm presenting here is extracted from the Tessy HIV/AIDS database. So Tessy HIV/AIDS is a joint database for reporting of HIV and AIDS diagnosis within the European Surveillance System, or Tessy. This Tessy database is coordinated by the European Centre for Disease Prevention and Control in Stockholm and the WHO Regional Office for Europe in Copenhagen. And all 53 countries in the region report annually their HIV and AIDS diagnosis to this database. And the data collection is focused on surveillance of HIV/AIDS, so case-based surveillance, not population-based surveillance, and on monitoring of the HIV care continuum. In this presentation, I'm using data on the annual number of newly diagnosed HIV infections in 2003 to 2015. And we chose 2003 to start with because that was the year in which our host country, France, started reporting on HIV diagnosis. And all the HIV diagnoses were stratified by the presence of a concurrent AIDS diagnosis, which is an AIDS diagnosis, a clinical AIDS diagnosis, within 3 months after HIV diagnosis. And for people who didn't have HIV/AIDS diagnosis, the diagnoses were stratified by CD4 cell count category. We tried to adjust for reporting delay and underreporting, and then we grouped the countries in 4 subregions, North, South, West, and East, according to the definition used by the United Nations. And a key assumption in this analysis is that we assumed that a measured CD4 cell count distribution in a subregion was representative of the entire subregion. And this is because some countries in Europe do not report or cannot report on CD4 cell counts at the time of diagnosis. And for those countries, we assumed that the CD4 cell count distribution was the same as in the other countries in the subregion to which the country belongs. In total, between 2003 and 2015, there were a bit more than 400,000 new HIV diagnoses in the whole region. So most new HIV diagnoses were in Western Europe, 144,000, then Northern Europe and Southern Europe, about 120, 110,000, and the smallest number of new HIV diagnoses was in Eastern Europe, but this was also the smallest region in this analysis. So we have data on HIV diagnosis, but they don't say a lot about HIV infections or the undiagnosed population. So to get information about the undiagnosed population, we use a method called back calculation. And this works roughly like this, as in this cartoon. So suppose you were to observe this number of HIV diagnoses over calendar time, then you can work out or back calculate the number of HIV infections in the past that gave rise to this observed pattern of HIV diagnosis. To be able to do this, you need to have information on the distribution of the time between HIV infection and HIV diagnosis. And that's the problem, because this information is often unknown. People who are diagnosed with HIV often do not know when they were infected with HIV. And also, the time between infection and diagnosis may change over calendar time, for instance, when there is more testing in more recent calendar years. But if you add information on CD4 cell counts or on the proportion diagnosed with HIV/AIDS, so then you get information on how long a person has been infected on average. And then you can work out this number of HIV infections in the past. So this back calculation method we used is actually very similar to the one in the ECDC HIV modeling tool. And like in the ECDC HIV modeling tool, we were able to simultaneously estimate the annual number of newly acquired HIV infections and also the distribution of time between HIV infection and HIV diagnosis by calendar year of infection. And once you know the number of infections in a calendar year and how long it takes before people are diagnosed, you can work out, you can calculate how many people are still undiagnosed by the end of 2015. If you do that for each calendar year of infection and then add up everything, you get an estimate of the total number of people living with undiagnosed HIV. Now, there's a catch here, because we didn't have data on HIV diagnosed before 2003. So we had to make sure that this method only gave a small proportion of infections that were acquired before 2003 and that were still undiagnosed by 2015. And because, as you will see later, the time between infection and diagnosis was quite short, this condition was fulfilled. It was less than 5% of the people undiagnosed in 2015 were estimated to be infected in 2003 or earlier. As a result, estimates are only accurate for relatively recent calendar years. To check whether this method worked, we used data from the Athena National Observational HIV cohort in the Netherlands, for which I'm working, as already mentioned by the chair. The two plots here show on the left the number of HIV infections, and on the right the number of people estimated to be still undiagnosed in each calendar year. And the gray lines are the results when you use all available data in the Athena database, while the red lines are the results when you only use data from 2002 onwards. And as you can see from these two plots, in most recent calendar years, the red lines and the gray lines actually overlap quite well, including the confidence intervals. So this gave us some confidence that this method may actually work. So these are the results of the analysis. So for the total EU EEA, we estimated there were 120,000 people living with undiagnosed HIV. And note that this is a little bit less than in the beginning of the presentation. This is because since last year, we got a few new data coming in and new correction factors for underreporting and delayed reporting. Now, the highest number of people living with undiagnosed HIV were in Western and Southern Europe. The smallest number in Eastern Europe, and Northern Europe was in between. And for those of you who can calculate quite fast, you may have noted that these four numbers by region don't add up to the 120,000, actually 113,000, I think. And this is because the total analysis was, the total number for the whole EU was obtained in a separate analysis, where the time between infection and diagnosis was forced to be the same across the entire region. This was not the case in the regional analyses. We also looked at the infection rates, so the number of HIV infections per 100,000 people living in each of the regions. So for the EU EEA in total, 5.3, this infection rate was 5.3 per 100,000 people. And the highest infection rates was actually found in Northern Europe. And as you may remember from the previous slide, they have one of the lowest number of undiagnosed people. And the lowest number of people, the lowest infection rates were found in Southern Europe, 2.7, and with Eastern Europe just a little bit higher, 3.1. As I mentioned, we could also calculate the time between HIV infection, HIV diagnosis, and estimate the Cd4 Count Distribution in the undiagnosed people living with HIV. So for the whole EU, the median time to diagnosis stands at 2.9 years, with a interquartile range 1.4 to 5.4. The plot on the right top shows the median times to diagnosis for each of the sub-regions. So it's a bit higher than average in East and Southern Europe. Regarding the Cd4 count distribution in the undiagnosed population, we estimated that 47% of the people living with undiagnosed HIV by the end of 2015 had CD4 cell counts above 500. And 31% of the people had CD4 cell counts below 350. So they were having late-stage infection and still not diagnosed. And as you may see from these two plots, a shorter time to diagnosis correlates with a high proportion of people living with undiagnosed CD4 and higher undiagnosed HIV infection and higher CD4 cell counts. Here are some strengths and limitations of this analysis. So one of the strengths is that we only need routinely collected surveillance data that is already reported into the Tessy database, so you don't need to do extra data collection. And there's also no need for historical data that when it's not there, it will never be there anymore. And because you don't need so many historical data, this may actually be a stimulus for countries to improve their current data collection, and in a few years' time, they may be able to use this method to estimate the number of undiagnosed people in their own country. There are, however, several limitations. This method doesn't give an estimate of the total HIV epidemic. It only gives an estimate of the number of people living with undiagnosed HIV. So you would need additional data on the number of people living with diagnosed HIV, which is quite a challenge in Europe as well, because we know a lot about HIV diagnosis, but there's limited follow-up data, and we don't know whether people died or moved out of the EU. We could also do adjustment for incomplete coverage, especially in Italy and Spain. They only reported for the whole country since a few years. And the adjustment for underreporting could only be done for the most recent calendar years and may not have been complete for years before 2011. So in conclusion, a substantial number of people in the EU EEA are living with undiagnosed HIV, 120,000 people. And the number of undiagnosed people is highest in Western and Southern Europe, but the infection rates are highest in Northern Europe. And the estimated Cd4 cell count distribution suggests that approximately half of the people are still in an early phase of their infection, because they have Cd4 cell counts above 500. But a significant proportion, 31%, are already in late-stage HIV infection, suggesting that more efforts are needed to test and diagnose these people. Finally, I would like to acknowledge the contribution of the ECDC HIV surveillance and the Dublin Declaration networks. Thank you very much.
Thank you for this great presentation. Any questions? Okay, I will have one question. I mean, you mentioned that in some region, I mean, Cd4 count maybe was more missing than in other region. Maybe you can tell us about which were the region where it was the case?
I actually don't know which regions were missing. It's more country by country, and
okay.
it differs quite a lot which countries. It can be countries in the west and the east. It's a bit scattered.
Okay. Okay, so I guess we will, conclude this session. Just, before, thinking the speakers, I would like to sum up quickly the key result of the presentation and highlight the main challenges that we still need to face. But before doing that, I wanted to remind that knowing EU epidemics is a key and maybe the key step in the fight against HIV, and all the work that were presented in this session contribute to a better understanding of the HIV epidemics, and effort in that direction needs to be pursued. So in several presentations, we saw that in many countries, at the national level, we were close to reach the last two 90s, but getting to the first 90, so finding the undiagnosed remained the biggest challenge. We also saw that in the presentation that HIV burden differ across geographic areas and age groups, that children, young people and men are in general less aware of their HIV status, and the proportion of virally suppressed is lower among men, young people and children. So accounting for these heterogeneities and feature is very important when scaling up and intensifying HIV intervention. Art van Siegen presented some estimates of the time from infection to diagnosis, and I think this time, and more generally, the timing in between steps of the care continuum is an important metric that we should be studied more to make sure that everybody will access treatment earlier and early in the course of the HIV infection, and ideally within the same year of the HIV infection. Last point before my final message is that we also need this kind of work to be carried out for key population, because what we found for the general population may not apply for key population, and we need data on key population to tailor intervention for them. A recent systematic review conducted by Ruben Granish showed that the data are limited for key population, and when data existed, it was mainly in high-income countries. So my last message is more for the civil society. So today, in countries that provide HIV treatment to all people, HIV-positive people will live longer if they know their HIV status, rather than if they don't know it. And if they take well their treatment, they will not transmit HIV to others, even if they have unprotected sex. So we should make sure that these two main achievements are known by everybody, not only the scientific communities, and they should, because they should contribute to reduce stigmatism associated with HIV, encourage people to test more often, and in turn help eliminating the HIV epidemics. So I would like to thank again the organizer of the conference for the session, the speaker for the great presentation and discussion, and the delegates and the volunteer. If you want to meet with the speaker that conducted the studies in Southern Africa, there is a poster session that will start just after this session, so you can discuss more with them. And so enjoy your conference, and you stay in Paris. Thank you.